Welcome to the second module on pulmonary and lung ultrasound entitled Consolidations and Infusions. You should have seen the first module regarding interstitial syndromes. I'm Dr. Gordon Johnson with Legacy Health. So to go over our learning objectives here, first we're going to identify the probes and the settings to do lung ultrasound. We'll talk about probe and patient positioning, some of the anatomy of surrounding landmarks, and then we're going to learn to differentiate what should be normal lung from consolidated lung, and then we'll talk about simple, complicated, and loculated pleural effusions. So first of all, which of the probes do you want to use to do lung ultrasound? When you're looking for pleural effusions and lung consolidation, actually, most people would recommend you're using the curvilinear or phased array probes because they're going to see deep down and they're really good at differentiating consolidation and fluid. Again, the linear probe is better for lung slide and superficial imaging. I like to keep it on the abdominal setting. I encourage you to play with all the different settings. I find personally lung settings are better to look at lung slide, perhaps A lines. Abdominal settings are really good to look at fluid. I have used the cardiac settings, but know that your images are going to be reversed when you reverse to the cardiac setting. But especially if there's a lot of movement, the frame rate of the cardiac setting is really good to see when there's movement in an image. So I always recommend you start at the liver, especially in an obese patient. Sometimes it's hard to identify landmarks, so I just start at the liver if the patient's lying in bed, and just with your knuckles to the bed, slide gradually up towards the axilla, and you'll usually be able to identify pathologies at the lung base there. So the first thing we think of is to look for the lung curtain. So this is simply by just having the patient take a deep breath, and you see the normal lung creating this gray shadow come down and form a curtain over the lung. Again, it's very important to have your knuckles to the bed so you're at the dependent portion of the lung to see any dependent fluid. And then you'll also see the absence of the spine sign here. You see the spine. There's the lung curtain coming across, but it also just disappears here, which tells you there's no consolidation or fluid there. Now, the other thing to remember for novices when they're doing this, I've seen a lot of people get confused thinking that the hepatorenal space is the diaphragm, and above that is consolidation, but that is simply the liver. Above that, the diaphragm here is pictured here. Note that a lot of it is shadowed out from a normal lung. You don't usually see the whole diaphragm unless there's fluid or consolidation above it. But again, it's important to identify those normal landmarks, go down, identify the kidney, go back to the liver, and then go up to the lung. So the way, if the patient's able, I like to actually image them sitting up. I usually do this after I auscultate the lungs, and you get a nice view of the posterior lung. And again, to see if there's any dependent fluid, you can see the liver here, and then the shadowing from the lung. Now again, if the patient's lying down, this is what you're going to see with a pleural effusion. Again, you can identify the liver here, the hepatorenal space, the diaphragm. All this anechoic is fluid here. You get a little bit of compressive atelectasis of the lung here that you're seeing. And then again, here you see a positive spine sign. You can see the spine all the way through, or normally this should all be shadowed out from the lung. Again, just to go over the anatomy, so the liver, the kidney here, the diaphragm, the lung in this area, the spine down here, and finally the pleural fluid. So you'll hear something referred to as the jellyfish sign. So here we were down in the Caribbean and we actually were swimming with a jellyfish, so I pulled one out of the water, put it in this bucket and imaged it, and you can see it there on the left. And you can see why they named this the jellyfish sign. This is the anilectatic lung here, and it does look very similar to a jellyfish. Here's the spleen, the diaphragm, here's the fluid around it. Again, on the left you can see the jellyfish, but you can see its stingers there that differentiate it from a lung, just in case you get that confused. So Here's again an example of a simple effusion with compressed atelectasis here, fluid around it, the jellyfish sign. The diaphragm would be down in this region, and this is the chest wall. Now, occasionally in simple effusions, you'll see one or two strands, fibrinous strands within that there. But if you're seeing more than that, these are generally complicated diffusions, and this does change your differential. This is something inflammatory, likely infectious there. Here's another example of a complicated pleural effusion with the liver, the diaphragm, and all these septations here. You can see this is going to need a chest tube, possibly even a VATS to evacuate. This actually is a TB case, so they're just treated medically, but most other effusions that look like this need to be drained, and not just with a thoracentesis. So here's an example of a complicated effusion. You see the ultrasound over to the right. Here's the CAT scan over to the left. And I just use this to illustrate the CAT scan is not nearly as good at showing these septations. So I find the ultrasound really helpful to know if this is going to need a chest tube, is it going to need a cardiac surgeon to go in there and decorticate everything. Here you can clearly see this is all septated and is not going to do well just with a thoracentesis. The next thing I wanted to talk about is lung consolidation. So this is when the alveoli are completely filled with fluid here. As you can see in this diagram, this is an example of a consolidated lung. Again, here's the diaphragm, here's the liver, all the consolidated lung up here. Here's another example of consolidated lung, liver, diaphragm, lung consolidation. Very heterogeneous here. This was actually done in Africa. I'm not sure what the diagnosis was here. This poor gentleman had a very severe pneumonia. We didn't have the microbiology to back it up, though, to figure it out. You can actually see part of his descending aorta here because the sound is being transmitted through, all the way through the chest. Again, there's the consolidation. And here you might be able to see a little bit of a hint of sometimes some air bronchograms. This is pretty pathognomonic of a pneumonia. Here's a better example, consolidated lung. Here you can see the air bronchograms as the patient is breathing. You see this going up and down. Very typical of a consolidated pneumonia. This was a couple of our residents actually that were scanning in India and sent this to me. So again, diaphragm, spleen, effusion, septations here with fibrinous strands, consolidated lung, air bronchograms, pathognomonic for pneumonia. So this was a case of pulmonary tuberculosis. Here's an example of a focal consolidation, but it's actually up higher in the chest. So you'll see as we scan down, you get into normal lung, then you get into compressive atelectasis and a parapneumonic effusion. So consolidated lung, relatively normal lung here, aerated lung here, some B lines, and then briefly down atelectasis and effusion here. Just again another example of a effusion. Again, you're seeing the heart here. Normally you would never see that through the chest wall, but because of this effusion, you can see the heart. And that's the end. Happy scanning.